Speaker is online. First of all, I would like to welcome you all again in the third session of the day 3. I welcome Dr. Mukesh Doble, sir. Again, sir, in the 5-day program. Uh, we have already introduced Doble, sir, in the inauguration session. If some of the participants could not attend the inauguration session, Doble, sir, to all of you. So Mukesh Doble, sir, is the emeritus professor in the Department of Biotechnology at the IIT Madras. His research interests are in the biomaterials, drug design, bioreactors, and bioremediation. He holds graduate and postgraduate degrees in the chemical engineering from the IIT Madras and PhD degree from the University of Aston. He has authored 320 technical papers and 10 books and filed 15 patents. He is also director of 2 startup companies in the biotechnology. He is also a fellow member of Royal Society of Chemistry, London. And he is amongst the top 2% scientists in the world as per the list prepared by the Stanford University, USA, 2019. He is also a member of American and Indian Institute of Chemical Engineers. So, I welcome Professor Doble, sir, and I ask him to share your views on the topic which is given by him, polymeric prosthesis with ease with case studies. Doble, sir, please.
Thank you, Professor Utkarsh, for the introduction. Good afternoon, everyone. I'm going to talk about polymeric biomaterials, and after an introduction on the topic of polymeric biomaterials, I will give some case studies which we have worked closely with some hospitals where we have shown how biomaterials could be used to solve some problems. Okay, let's start. Yeah. Okay, polymers are widely used as biomaterials, as implants, as part of the devices, and as a drug delivery vehicle. So many applications polymers are finding in the area of implants. So as you know, the definition of a biomaterial is implants, devices, or tissues that are placed inside the body or on the surface. You also have surface-based biomaterials like wound healing patches and so on. So this could be replacing a body part. It could be helping the function of a body part, like a left ventricle assisted device. It's improving the existing function. So it can give support to the body part. It can be used to grow tissues, organs, and so on. So polymers have a lot of properties which metals do not have. So they do have many applications in the area of biomaterials. So if you look at polymer, there are 2 types of polymers, the artificial or the synthetic, we'll call it, and of course the natural polymers. Okay, natural polymers, we call it biopolymers. These are made by, say, microorganisms or animals or plant species. So they are found, they're extracted and used as biomaterials. So they have many advantages, they have many disadvantages also. I will briefly talk about that later. If you talk about artificial biomaterials, they are synthetically made. That means you use chemical synthesis to make the monomer. Monomer is the building block of a polymer. And then you start growing the polymer, long chain polymer. Okay, these are called artificial or synthetic biomaterials. Okay, uh, of course, polymers, and you can also have ceramics, silica, zeolites, carbon, and so on. These are called inorganic material, oxides of alumina, oxides of silica, oxides of zirconia. They are also very biocompatible. They are called inorganic material. They have many advantages and of course some disadvantages also. And then of course we have the metals, titanium, stainless steel, chromium, cobalt, iron. These are metallic biomaterials. They also find a lot of applications in implants and devices. So each one of these biomaterials, they have different advantages, disadvantages. They have different applications in different parts of our body. So there is nothing like one single biomaterial which can be used in any part of the body for any duration, time duration. Actually. And of course, now we have combinations of biomaterials. For example, we can combine some inorganic material like silica uh, or fibers into some polymers like PMMA, and then we can get a very biomaterial that's called composites, which are extremely strong. For example, I can have a fiber reinforced polymethyl methacrylate. Polymethyl methacrylate might not have very high strength, but once you put in certain fibers, it becomes extremely strong. Okay, or we can have silica like material incorporated in polymers. So these are called composites. So composites have totally different properties. They take advantages of both the inorganic material as well as the polymers. So again, composites have find a lot of applications as biomaterials. Then we can have blends, that is combinations of two polymers. I can have, for example, lactic acid and glycolic acid. Glycolic acid based biomaterials are very hydrophilic. Lactic acid is a little bit hydrophobic. So I can have a polylactic glycolic acid. That means a combination of lactic and glycolic. Okay. I can have a biomaterial which is made up of, say, styrene and methyl methacrylate. Okay, so combination of styrene and methyl methacrylate. So we can have, these are called blends. So combinations of two polymers. So we get advantages of both the polymers. So that's the main advantage of polymers. We can make blends, we can make composites. So we get very excellent properties which cannot be made with either say ceramics or with metals. So that's why polymers are taking over quite a lot of applications in our area of biomaterials and for drug delivery applications. For example, if you look at intraocular lenses, okay, these are made up of HEMA, hydroxyethyl methyl acrylate type of polymers, or they are also made up of polymethyl methacrylate. So you can see big uses. The numbers in the bracket gives you a number of intraocular lenses that have been implanted. Hip and knee prosthesis. So we can have materials, polyethylene type of polymers, ultra high molecular weight polymers being used in hip joints. Okay, sorry. Then we can have vascular grafts. Vascular grafts made up of polyesters. Okay, they are called large diameter vascular grafts, or small diameter vascular grafts like polytetrafluoroethylene. So when you're replacing certain veins because of injury or because of blockage, only polymers are used, like polyesters or polytetrafluoroethylene. Heart valves, polyurethanes are used quite a lot as heart valves, artificial heart valves. Then catheters, catheters, polypropylene based catheters, polyvinyl chloride based catheters. Then we have stents. These are urinary stents, which are made up of polyurethane. And of course, cardiovascular stents are made up of metals. And there is a lot of research that's going on where you are looking at biodegradable cardiovascular stents. Maybe in another few years, we may have those. And of course, the biomaterial business is a huge business, more than 80 billion US dollars. The top one, of course, is metals, stainless steel, titanium, zirconium, cobalt, chromium, and so on. Then comes polymers, the second largest selling material used as biomaterial or implants. Polymers are classified as thermoplastics, thermosets, and elastomers. Okay, thermoplastic, as the word implies, if I heat it, it will become soft. So we can make it into different shape, and then when you cool it, it becomes hard. Okay, so heating and cooling, we can change the shape and its flexibility. Food packaging, insulation, um, many applications, polyethylene, polypropylene, like that. Whereas thermosetting is, once it is set, it's not going to be again softened at higher temperature. So it will be brittle after that, actually. Okay, vulcanized rubber, polyesters, all these are hard and brittle. Then, of course, we have elastomers, rubbery like polymers. Rubbery like polymers will be like a polyurethane, which are used in urethral stents, or we can have rubber based material which are used in drain pipes and so on. So they are elastomers, rubbery type of material. So thermoplastics, a lot of polymers which can be shaped by increasing temperature and cooling it. Thermoset, you have a set shape and size, you don't have the freedom to change them. Okay, and then of course the elastomers. Like I mentioned, you have natural and synthetic polymers. Synthetic polymers like polylactic acid. You can see on the right-hand side of the screen, polylactic acid, polylactic glycolic acid, polycaprolactone, polymethyl methacrylate, polyethylene glycol. So all these are approved by FDA and they are used in our body. For example, polylactic acid is used, polylactic acid screws. They are biodegradable, so after a prolonged time, in the body, it will slowly disappear. Okay, polycaprolactone, it's used as drug delivery. Polymethyl methacrylate, it's used in our dental implants. So widely, you will find it in our mouth. Polyethylene glycol is also used for drug delivery. All these polymers, which I am talking about, synthetic, they are approved in FDA. They are widely used in our body. If you go to natural, there are two types: polysaccharides. Saccharides means sugar-based, and then protein-based. So sugar-based, protein-based. We have protein-based like collagen. For example, our bone contains a lot of collagen. They are all protein-based. Fibrin, okay, like blood. Then silk. These are all protein-based. That means they will have amino acids as their repeating units. Different types of amino acids, different ratios, so different properties. The left-hand side, you have polysaccharides. Polysaccharides, sugar-based. Starch, alginate, chitin, chitosan, glucon, curdlan. So many types of sugar-based. They will have sugar as their moiety. They will have repeating units of sugar connected, branched, connected with different linkages, beta 1,3, beta 1,2, beta 1,4, beta 1,6. So you have different types. These are all polysaccharide based. So the natural polymers, as they are very biocompatible, they will not have much toxicity, unlike synthetic polymers. Some of them will be recognized by the cells, so tissues can be grown, so they can be used for as for tissue scaffolds and so on, actually. Okay, so that's the advantages. They are biocompatible, recognized, cell adhesion, differentiation take place, and of course they have very poor mechanical strength. We can't use them in load bearing applications. That's big. And they can be and they sometimes elucidate immunoresponse, because some of these polymers, when they are taken from animals, for example, chitosan like polymers, they may have certain toxins coming from the source. Okay, so that's a problem. And of course, limited supply. If I want to have thousands of kgs of silk, okay, then that may be very difficult. Whereas natural polymers, so that's the problem with the natural. Whereas synthetic polymers, we can manufacture PLA. There are very large plants running to tons of PLA production per year. So that's the advantage of that. But some issues like cell toxicity or cell growth adhesion could be a problem. These polymers sometimes degradation may be a problem. It might not degrade. Even if it degrades, the degraded product could be a little bit toxic. For example, if you take polylactic acid, if it degrades and lactic acid comes out, then it may have lactic acid is an acid, so it may have okay, acidic pH condition around it actually. So that problem is there. Okay, I just want to show some of these pictures where we have used polymers. This is a polylactic acid screw. Okay, it's used in ligament. If there is a ligament tear, they incorporate this, and when the ligament gets healed, simultaneously the screw also starts getting bioresorbed, and it will disappear. You can see these are some open wounds where, and they are using a titanium or a stainless steel plate to hold the bones. There will be a lot of infection that's coming in, so they use a polymethyl methacrylate beads. Here you can see polymethyl methacrylate beads incorporated with the drug antibiotic. So the antibiotic gets slowly released, and it keeps the bacteria infection under control. Of course, PMMA is not biodegradable, so that's a big disadvantage. So you have to think about some polymers which can degrade, release the drug, and degrade also. Whereas, as you can see, PLA is degradable. These are polyurethane urethral stents. As you can see here, there's an X-ray picture. This is kept. This is in the ureter region. It can be kept between the kidney and the bladder, so the urine flows. So if there is a blockage in the ureter, the urine doesn't flow. So they keep these urethral stents in between so that the urine flows nicely. Okay. But polyurethane is very flexible. It's like rubber, so it's very it's placed inside the body. Generally, it's placed for 4 to 6 weeks, and the doctor has to remove it again because it's not biodegradable. Suppose we have a biodegradable polymer, if it can slowly degrade, the doctor does not have to perform another surgery to remove this. We have been working on this type of polylactic glycolic acid urethral stents. They are biodegradable, okay, over a period of time. So you don't have to do a second surgery. So this is in the ureter region. Okay, these are called polytetrafluoroethylene based shunt. As you can see, these shunts are placed between the pulmonary artery and the aortic branch. So the blood, as you know, from the left ventricle goes through the aorta to all the rest of the body. So here, this shunt is placed. So blood is okay, taken into the pulmonary artery, and the blood that flows to pulmonary artery gets oxygenated actually. So when the blood does not have enough oxygen, so this type of surgery is performed so that the blood is again forced into the pulmonary artery, which takes the blood to the lungs where the oxygenation takes place. Okay, so these are carried out on pediatric, that is babies who have hole in their heart. So there they use a polymer called polytetrafluoroethylene, as you can see here in the surgery. So different types of polymers I have been showing. This is a ultra high molecular weight polyethylene. So these are used in knee joints. Knee joints, they have a cobalt, a chromium, ball and socket type of joints. If the metal touches the metal, there could be rubbing, and metal wear and tear, metal release could be happening. So what they do is they keep a ultra high molecular weight polyethylene in between as a spacer. So direct metal on metal contact is not happening actually. So there are a lot of knee surgeries are done, total knee replacements it's called. So the ultra high molecular weight polyethylene is kept there actually. So as I've been showing, a lot of different types of polymers, different locations of the body, different requirements. For example, I want this urethral stent to degrade after about 6 to 8 weeks. I want this polymethyl methacrylate, which releases antibiotics, to disappear within 2 weeks. Whereas I don't want this shunt to degrade, and I don't want this polyethylene to degrade, because this total knee replacement is meant for 15 years at least. Okay, so different polymers, different locations, different properties, different requirements. So that's the biggest challenge in using polymers in different locations of the body actually. And the beauty is it's possible to achieve that um, by selecting different polymers, by looking at polymers blend as well as composites of polymers. Okay, so they have many advantages: easy to make, complicated, tailorable physical mechanical properties. We can modify the surface because surface is in contact with the rest of the body fluids, and hence there could be some immune response. So we can modify the surface so that immune response is reduced. Okay, we can modify the surface so that the cells can get attached. We can prepare biodegradable polymers if we want the polymer to degrade. Okay, so many advantages. Metals don't degrade for us. So if somebody has a titanium screw or a titanium rod, it's going to be there forever and ever actually. So that's the main disadvantage of metal. But some disadvantages: it can leach out some raw materials, it can leach out some chemicals, it can have some wear and tear, whereas metals are very very wear resistant. So that is an disadvantage. If you don't want the polymer to degrade, but if it is got some biodegradable properties, then that's a disadvantage. For example, a body may contain oxidoreductase type of enzyme, contains lipase, amidase, esterase. So all these enzymes found in blood and other places can slowly start attacking the polymer. There could be some degradation taking place, but such things will not happen to metal. But of course, metal has different problem like corrosion. Stainless steel has corrosion, so it can get really spoiled. So metals have different problems actually. Composites combination, like I said, it's a combination of a non-metal and a polymer. So we can have carbon reinforced plastic, or we can have fiber reinforced plastic. So the plastic could be different types of polymers. The fiber could be the additive fillers. They act like reinforcement. They give a lot of strength, mechanical strength to the material. They prevent wear and tear and fretting. So many advantages of that. So very tailor-made, specific applications. These type of composites can be made. Catheters, silicon rubber, as you know, does not have any strength. It can tear. So when you incorporate silica, it becomes very very tear resistant. Again, silica with the PVA or hydroxy propyl methyl cellulose cartilages. So cartilages have to take up a lot of mechanical load. So these type of composites can have many advantages actually. Okay, then carbon, glass, reinforced polymers. It enhances strength and modulus. Carbon fiber gives you high stiffness, tensile strength. Silica glass also is used quite a lot in dental fillings. Okay, then many advantages are there nowadays. Carbon fiber reinforced polyethylene, it's it adds mechanical strength. So especially for load bearing and wear and tear applications like knee replacement, that's got an advantage. Of course, plates, screws, spinal segments always has been metals, but nowadays polymers are being used. Polymer composites are being used, carbon reinforced polymers, and because the main advantage is polymers are very lightweight when compared to metals. Only disadvantage is its mechanical strength and wear and tear. So when you incorporate a inorganic material, it can overcome such problems. So many advantages are there, and slowly polymers are being used where metals have always been the real product actually. Okay, of course polymers have many. We cannot have one single polymer for all applications, because sometimes we may need it for 2 weeks like drug delivery, or we may need it for 6 weeks like your urethral stent, or you may need it for 10-15 years, that is forever, if it is used as a cardiovascular shunt. So the time duration also changes, location also changes. Blood contacting region, if it's in urethral region, it's a urinary stent. You have urine contacting region, then you have other body fluids contacting. So we have different interaction between the body fluid and the polymer. Okay, so the inflammatory responses could be different, infection could be different. Okay, so depending upon where it's being used, for how long it's being used, and what type of body fluids is getting exposed, we need to design polymers according to that. Actually, that's a very, very important. For example, if you look at it, these are dental implants. So we have biofilms of different types of bacteria sitting there. Especially our oral cavity contains a lot of organisms, bacteria, yeast, and so on. So that's a big problem. Look at this fractured plate. Because it's an open wound, a lot of bacteria from the environment goes and sits there. Okay, that's a problem. That's called a biofilm. Look at this. This is an artificial valve. Okay, placed in the cardio region. Again, bacteria in the blood goes and sits on it. Okay, so the biofilm, that's a serious problem. If you look at the stents, urethral stents, which is used in urinary region, as you know, urine contains a lot of salts, calcium, magnesium, salts. Okay, struvite, apatite, salts. So salt deposition is a problem. Urine also contains bacteria like Protease mirabilis or E. coli. That's a problem. So this is a picture of that actually, which is placed in the inside the urethral region actually. A lot of encrustation and bacteria sitting on it. So biofilm formation is a big problem. Attachment of these on the surface of the material is a big problem, as I showed you in these pictures actually. These are called biofilms. This is Staphylococcus aureus. This is a microorganism found quite a lot, forming biofilm on a polyurethane. So once the bacteria sits and forms a biofilm, biofilm will contain exopolysaccharides, okay, then proteins, dead cells, live cells. So the bacteria which is right inside is very safe from antibiotics. So that's one of the biggest problem. The bacteria which is well embedded inside the biofilm do not die so easily of antibiotic. So it's been seen that killing a bacterial biofilm will require 10 times more antibiotic than a bacteria which is floating inside the blood. Okay, this is a Pseudomonas aeruginosa biofilm, again polyurethane. Pseudomonas aeruginosa is involved in many pulmonary diseases. Okay, so what are the entry points for these bacteria, infectious organism? It could be because of the periodontal disease. So people who have a lot of problems with the dental, so microorganisms could be entering. Catheters, if somebody goes to a hospital and gets in the bed for some time, So they introduce these catheters for removing the urine, or even putting in nutrients. So these are entry points. Other one is, sorry, implant. If the body is open to place an implant, total knee replacement, or cardiovascular stents, or urethral stents, or orthopedic bone replacement screws or plates. These are called open wounds and implant surgery. So all these are entry points for the bacteria, and they start settling down, forming biofilm. So they become very difficult to remove them, kill them. So very strong antibiotics have to be used, or large concentration of the antibiotics has to be used actually. Of course, biocompatibility is very important because the material is going to be placed inside the human. So there has to be a good compatibility between the human cells and the synthetic material. The material should not invoke any toxic response to the cells. It could be genotoxicity, or it could be nephrotoxicity, or it could be short-term, long-term toxicity. So all these needs to be looked at. Okay. Some toxicity can lead to inflammation. Long-term toxicity could have very serious implications, and so on. So is it going to have any response to the blood? Because blood, all the red blood corpuscles and platelets are moving around. It should not elucidate any response. Okay, that's a problem, especially when you are using membranes in hemodialysis, which are in contact with the blood flowing region. If you are using a urethral stent, then there is no contact with the blood. But if you are using a cardiovascular stent, or if you are talking about diaphragm valves, or if you are talking about shunts which are in contact with the blood, then the material should have a good blood compatibility. Okay. Now, if you are talking about urethral stents, of course, we have to think about preventing the salt incrustation, preventing the bacterial adhesion. We don't want the bacteria to adhere to these surfaces of the stent. So the requirements are becoming very difficult. I mean, different as well, depending upon where it's going to be placed actually. So biocompatibility is generally the surface of the material. It is not the bulk. You may have a big stent, but then you may have a big implant, but it is the surface which is in contact with the body fluid. So how the surfaces are designed, that is the important research challenge actually. The surface should be compatible to the body fluids. Okay, it should not cause any inflammation, or it should not cause any unwanted reaction to the host system actually. So it's a surface phenomena. Biocompatibility is a surface phenomena actually. So there are a lot of techniques techniques are available to modify the surface of a biomaterial, so that it doesn't lead to all these problems. A lot of techniques, mechanical methods, chemical methods, biochemical methods, and so on actually. That itself is a separate lecture as such. So, as I said, materials which are going to be in contact with the blood, it should also have blood compatibility. Okay, it should not have platelet aggregation. It should not make the red blood corpuscles to get activated. Okay, once thrombus is formed, thrombus is nothing but blood clotting. Once you have a blood clot and the clot starts traveling towards cardiovascular region, you could have a blocked artery, or if it goes towards the brain, then you could have a stroke. So that's a big problem we need to keep in mind for blood contacting region actually. Protein absorption. Body contains a lot of protein, albumin, immunoglobulins, fibrinogen, high molecular weight, kinogen. So all these are proteins of different molecular weights. They're all floating inside. We don't, so they may get absorbed on the surface. So once they get absorbed on the surface, you may have different properties. The material may start swelling. That is, your biomaterial may start swelling. So we need to understand this type of protein interaction with the biomaterial surface. So platelet is important component of the blood. Okay, so the platelet adhesion, platelet activation, platelet should not get activated. Once it gets activated, start aggregating together, and then you end up having a thrombus formation, and they settle down. Sometimes they start even going downstream. So all these are because the platelets got activated by the biomaterial which is placed inside the body actually. And then of course you have inflammation happening because it's a foreign object that's being kept in. You can have acute inflammation, chronic inflammation, granulation tissue. The tissues may start growing and completely cover the biomaterial, fibrosis. All these are inflammatory responses which can lead to very serious issues, rejection of the biomaterial. So the biomaterial has to be removed, or it can cause very chronic uh, issues to the patient who has this particular implant placed inside the body. So inflammation also we need to study when you are designing biomaterial. So many things we have to study, like bacterial adhesion. We need to look at platelet aggregation. Then you have to look at inflammatory responses. Then we have to look at the degradation products, whether they are biocompatible, okay, where, and so on. Actually, these are biological studies I'm talking about. Of course, you may have to do physico-chemical studies also, but that is not part of the focus. Okay, the macrophages, which are involved in inflammation, they also start forming large bodies. Okay, then they may start engulfing the biomaterial, so it can lead to a lot of these type of issues. So surface modification. So if it's a cardiovascular region, then we have to prevent protein absorption. We need to prevent thrombosis or thrombogenicity. We need to allow the endothelial cells to adhere. Whereas if it is an urinary region, we have to again prevent protein absorption. We have to prevent bacterial adhesion, like urine contains bacteria like E. coli or Protease mirabilis. We have to also prevent salt formation, attachment, magnesium and calcium, struvite, apatite, all these salts. So as you see, so many, depending upon where it's going to be placed, we need to design the surfaces accordingly. Actually, okay. So it's not an universal solution, but it depends on the location of the biomaterial. Actually, okay. So like I said, there are many surface modification techniques there. You can see on the left hand side physico-chemical approaches, right hand side you have biological approach. So physical approach and then chemical approach. Physical, they use plasma, they use different types of radiation. Chemical means they use certain functional groups attached, like OH group, amino group, and they become more hydrophilic surfaces they pair, and so on. So there are many chemical covalent bonding of proteins, adsorption of proteins, like that. Those are all chemical-based methods. But if you look at biological methods, we can have certain macromolecules um, on the surface of this material. Okay, enzymes, enzymes which are biocompatible. These are called biological based methods. So surface modification of biomaterials to reduce thrombogenicity, to reduce bacterial adhesion, to prevent inflammatory response is a separate subject of its own. Actually, okay, we'll not talk about that. Okay, so many issues we talked about. Many polymers are used in the area of implants and prosthesis. A lot of surface modifications can be looked at depending upon the location of the polymer in the body and depending upon the duration of the material inside the body. Okay, it's a lot of research that's being done. And of course, polymers, main advantage, you can have blends and you can have composites. So, okay. And of course, because bacteria gets attached to the surface to form biofilm, and this type of biofilms are possible in any part of the body. For example, I showed you in the urinary region or in the cardiovascular diaphragm valves, or it could be in your mouth, oral cavity. Okay, So this biofilm bacterial attachment is a very serious problem. There are many techniques available to remove the biofilm. One is to prevent the biofilm formation, and the other one is to remove the biofilm which has formed, killing of bacteria. Okay, so different techniques are used. Okay, modifying the surface of the material, and coating of material, coating with the hydrophilic type of groups, coating with the antibiotics, antibacterial coating, and coating with the biodegradable polymers. That means some polymer slowly will degrade, so whatever gets attached is slowly getting removed. Okay, that is called the self-polishing surfaces. Hydrogels are used. Dendrite type of polymers are used. Dendrites means poly surfaces which contains polymers sticking out so that bacteria will not get attached. So different, again, this is a huge area uh, for preventing of biofilms, techniques available for biofilm prevention. So a lot of research is being done in this, and there is no single method for all the polymers, depending upon the type of polymer, depending upon the duration, depending upon the location. Different types of techniques are there to prevent biofilm formation. So we so far we have looked at what are the issues related to polymers and how they are overcome, what are the advantages of polymers, and how the polymers properties could be enhanced, okay, and so on. So let's now look at some of the research which we have done using polymers as the implant. We have worked in close collaboration with the certain hospitals to solve some of their problems, which involves polymeric biomaterials. Actually, okay, let's okay. If there is an open wound with a fracture, generally they for a fracture they use stainless steel rods or plates or titanium rods or plates screwed together with both the broken bones so that the bone starts growing. But the main problem here is when the wound is open, there is a lot of infection that's going to happen. Okay, when there is going to be infection, inflammation can happen. So even your the stainless steel or titanium plate could get infected, and it may get rejected. So one of the main worry for the orthopedic surgeon is to how to control and reduce the infection. Okay, so that is the first priority, whereas treating the broken bone is much easier for the orthopedic surgeon than this. So what, because it's an open wound, as soon as there is an open wound, a lot of bacteria enters and they form biofilm on the implant material. And as I said, biofilm bacteria are very difficult to eradicate. Unlike sessile bacteria, you may require even 10 times, 20 times more antibiotic. Still, it might not be completely eradicated at all. So the challenge in open wounds are how to prevent, control the infection. Okay, these are some open wounds, as you can see. So what they do is, some places they use polymethyl methacrylate beads, and this is a polymer. It's quite a ubiquitous polymer. It's used quite a lot in oral region, actually, dental cavity filling, artificial teeth. They use methyl acrylate, methyl methacrylate type of thing, actually. So they load it with meropenem, which is an wide range spectrum antibiotic. And then what they do is they keep it inside. You can see the plate here, which which holds both the broken bones. Then they keep this polymethyl methacrylate beads loaded with meropenem inside, and then close it. So the drug is slowly released from the polymer. And because the drug is very close to the wound area, it kills the bacteria. Whereas the patient taking drug orally, by the time the drug reaches the site of action where the infection is there, the concentration may be much, much lower. Okay. Whereas by keeping a drug loaded polymethyl methacrylate beads close to the wound area, you get a lot of blood concentration. So what happens is the wound is quickly healed. Bacterial infection is also under control. But the main problem with this polymethyl methacrylate is it's not biodegradable. Okay, so what happens is once the drug gets released, say about 10 days, 10 days is a crucial time which will keep the biofilm formation or bacterial adhesion and infection under control. After that, body will take care of healing the person. So once the meropenem gets completely used up, completely released from the PMMA beads, and the PMMA beads are just sitting there. The surgeons can't leave it inside because bacteria may again start settling on them. So what they do is they do a small hole surgery to remove these beads actually. So they have to perform another surgery. So that's painful. Okay. If you have a polymer which can prevent this problem, that means the polymer should degrade slowly after between third week or fourth week, and then finally get bioresorbed. Then the surgeon does not have to do another surgery to remove the PMMA type of polymer which is sitting there, which is not biodegradable. So we looked at different types of polymers which will take in as much drug, which can get loaded with the drug, release the drug in the first 10 days, and after 10 days it slowly starts biodegrading or bioresorbed. So in the next month or two it should completely disappear. So it should not cause any adverse reaction to the host, no toxic inflammatory reaction, as well as it should not lead to any inflammation. So ideally we should have such a polymer. So we looked at some polymers which are approved by FDA, that is Food and Drug Authority. So we ended up with polylactic glycolic acid. And the beauty of polylactic glycolic acid is it contains two monomers, lactic and glycolic. Glycolic is more hydrophilic, it degrades faster. Lactic also degrades, it's a little bit more hydrophobic, it degrades slowly. So we can modify the ratio of lactic to glycolic to get good degradation rates, or and also good drug loading rates also. So we looked at PLGA, polylactic glycolic acid. Okay, and then we loaded it with drug meropenem and then looked at how it degrades over a period of time for 30 days. Okay, so this is a polylactic acid. That means there is no glycolic at all here, the top graph. So in 30 days you can see polymer weight loses from 80 milligram to about 50 milligrams. Whereas when we have polylactic glycolic acid, we have more glycolic, almost 90% by weight to 10% of lactic acid. It degrades to almost 10 milligram. So almost 90% of its original weight is lost within 30 days. So when you have more lactic acid, the biodegradation of the polymer is much less. Okay, when we have more glycolic acid, we can achieve very good degradation. So you can see the particles also becoming smaller and smaller, starting from 270 nanometers going down to 100 nanometers here. Here we have 325 to almost 75 nanometers. So when the polymer slowly degrades, biodegrades, drug also gets released as a function of time over 30 days. So PLA is not able to release as much drug unlike polylactic glycolic acid. It's able to release most of the drug, whereas PLA is not able to release most of the drug. Almost 20-25% of the drug is still retained in PLA. Okay, so that's another advantage of this polymer. It's able to release as much drug as possible. It's also getting degraded much more than PLA, and so the released drug is able to kill the bacteria. You can see in the bottom graph that the bacterial count is quite low with the PLGA based drug release system when compared to PLA alone based drug release system. Okay, so we are able to achieve good degradation of the polymer nanoparticles. We are able to achieve good drug release with PLGA based nanoparticles, and also we are able to control the bacterial count to a much higher degree when compared to PLA alone. The advantage of this system is we can modify the ratio of lactic to glycolic to achieve different types of polymer with different degradability properties. That's the main advantage. So the hydrophilicity also could be modified by varying lactic to glycolic ratios actually. So as I said, more glycolic, you may have more hydrophilic surfaces, more degradability, whereas more lactic, less hydrophilic and less degradability. Of course, PLA also degrades, but relatively, that's what I'm saying. So as I said, we need to look at the cytotoxicity of these polymers which we have developed. So we look at how they interact with cells, okay, and whether the cells die because they are exposed to these new polymeric systems over a period of time actually. So this picture shows you after 4 hours of interaction with the polymer, green indicates live cells, red indicates dead cells, okay. So we can see many that there is enough compatibility in this new system and compared to the other system. Okay, so we are able to achieve a good polymer system, which is called the PLGA, which is able to absorb more drug, which is able to degrade much more faster than PLA, which is able to release more drug from the nanoparticles when compared to PLA. Okay, and the main advantage, of course, is we don't have to perform another surgery to remove the polymer devoid of all the drug. For example, PMMA, if you use, it will not degrade, so it will be sitting inside once the drug has been consumed or used up. And next problem, look at the next problem. This is a polyurethral stent. Polyurethral stent. Okay. So this stent is placed inside the ureter. You can see on the top figure. So we have the bladder at the bottom. Okay, so we have the kidney on the top. We have the bladder at the bottom. So the ureter is placed. So the urine flows here, comes down to the bladder. So sometimes this ureter is blocked because of stones or because there is some infection inside. So what they do is they keep this polyurethane-based urethral stent, so the urine can flow nicely through this. And generally they keep this for 4 to 6 weeks. Okay, so after maybe after 2 months, they remove it. Okay. So you can see the bottom figure here. The top figure shows a nice new stent. Bottom figure shows after 6 months. So some patient has had the urethral stent placed for 6 months. You can see the color. So a lot of salt incrustation because urine contains a lot of salt inside, magnesium, calcium, steroid, apatite, and so on. Actually, okay. Sometimes patients don't forget to get it removed because they have to go to the hospital to get it removed. So they forget, and when it causes real problem, after certain time they come to the hospital running. Otherwise, they don't bother at all. And so this is after 4 years. You can see a lot of salt incrustation. So sometimes patients don't come to the hospital to get it removed because of many reasons, personal reason. Only when it causes problem like inflammation, pain, and so on, they come running. So ideally, we should have a polymer which will slowly degrade and disappear after about maybe 2 months. so that the patients don't have to come back, perform another surgery. Polyurethane is a very flexible polymer like rubber, so it's very ideal to be placed inside. Okay, so another problem with this polymer is the bacteria can adhere to this polymer. Number one. Number two, salts, because urine contains a lot of salts. So somebody who is having a urinary problem, their salt deposition could be very high. So there could be a lot of salt deposits on the polymer. So when salts deposit, bacteria also deposit. So end up having infection, inflammation, pain, and so on actually. So ideally, we would like to have surfaces which prevent salt incrustation and which prevents bacterial adhesion. Okay, so we looked at some surface modification to prevent both actually. Okay, so when do they use this particular urethral stent? They use it after a stone surgery. So what they do is they perform a stone surgery. So all the broken stones will flow through with the urine through that, and we don't want a polymer, the stone to block it. When you have renal obstruction, when there is an infection, there could be renal obstruction. So all these are reasons. So you can see some X-ray pictures. You can see some X-ray pictures of these polyurethane urethral stents. Okay, you can see how they are. The bladder, knee. Okay. Yeah, sorry. These are some other pictures. You can see this one where the stent is broken. You can see 1/2 here, 1/2 here. This is an X-ray picture. So once the stent is broken, we may have to remove a bigger problem, bigger surgery actually. But that's not what we were looking at. We were looking at how to prevent salt incrustation and bacterial adhesion on these stents. Okay, so like I said, calcium, magnesium type of salts, calcium oxalate, struvite, apatite, then bacteria like E. coli. This is a bacteria which is quite a lot found in urinary. This is an uropathogen. This is UTI, you must have heard, urinary tract infection. So E. coli is one bacteria. Another bacteria is protease mirabilis. This is responsible for salt intrusion. So when the pH, this bacteria affects the pH of the urine. So when it becomes a more alkaline, start deposit. And of course, you also have Staphylococcus aureus because it's found, it's an ubiquitous organism found everywhere. And so we want to look at how to prevent these bacteria attachment on the urethral stent, how to prevent this salt incrustation. And ideally, these stents should work for 6 to 8 years. And of course, some patients may forget or don't bother for 6 months. So it should work during that period of time. Okay, a lot of salts deposit, calcium-based salts, as you can see here, calcium-based salt. These are atomic absorption-based studies where we can identify what type of elements that are found on the stents, calcium, magnesium type of salts. You can see a typical picture here. This is a scanning electron microscopic picture here. A lot of salt deposit, salt incrustation as you call it. These are salts you can see here. Hydroxyapatite, struvite. Okay, sorry. This is a atomic absorption picture, so we can find out calciums and magnesiums and so on actually. You can also see the crystal, struvite crystal, hydroxyapatite crystal and so on. Okay, so what we started doing is we thought of a polymer which is called polyvinyl peridone iodine. This is a polymer because it contains iodine and it slowly releases iodine over a period of time. And as you know, iodine can be antibacterial. So when we coat the polyurethane with this particular polymer, as the iodine slowly gets released over a period of time, you can have a antibacterial surface. So the main advantage is we can prevent bacterial getting attached. So we modified the surface with this particular polymer. This is called a surfaced modified. So different techniques. I will not go too much into that techniques which we followed, but different techniques we used for this to get a very effective PVP iodine coating on the surface of polyurethane. So once we do it, we looked at how the bacterial attachment takes place. As you can see in the top bar graph, the third graph, you can see a big decrease in the bacterial adhesion, staph adhesion. So this scanning electron picture shows you how the bacteria is sitting on unmodified surface. Once we modify the surface, you can see that bacterial adhesion is completely gone. Completely gone. This is with another organism. This is called Pseudomonas aeruginosa. Again, on the left-hand side, scanning electron picture, you can see a lot of bacterial adhesion. That's called biofilm. On the right-hand side, there is no bacteria at all. So the surface is the modification is extremely good. It can reduce the bacterial adhesion by many folds. Actually, then what it does to the salt encrustation also we saw. Okay, so these are some salt encrusted surfaces. So big decrease, you can see from the atomic absorption studies, a big decrease in the attachment of salts or salt encrustation. So we took the entire stent and did the modification, and then we tried to monitor how the bacterial attachment takes place. So you can see on the left hand side, unmodified surface, you can see a lot of salt. On the right hand side, you can see absolutely the surface looks very good. The polyurethane surface looks very good, modified polyurethane surface. Okay. Then because the salts don't encrust, we can also look at how the bacteria get attached, like Staphylococcus aureus. As you can see here, a lot of bacterial biofilm, but once we modify the surface, you can see on the bottom side, there is no bacterial adhesion. This is one bacteria, this is another bacteria like Pseudomonas aeruginosa. Again, you can see very clean surface here, absolutely no bacterial biofilm that's formed. So this modification seems to work very well. We are able to prevent both salt incrustation, and we are able to prevent the bacterial biofilm formation. So what we did is we tried to test it out on animals first. So we did some small animal studies to see how this material affecting the small animals. So we took rats or mice. Then they were in these modified polymers were implanted inside. We call it intraperitoneal, and then it's closed. And then after 30 days, these polymeric materials are removed, and then we look at what are the inflammatory response, or if there are any fibrous tissue formation, capsule formation, is there any giant cell formation, and then what is the effect on the various genes which are involved in the inflammation. So we did a very detailed study after keeping the material inside for 30 days. Okay, so that's how this entire animal-based studies were carried out. Okay. Okay. So after 30 days, this is the we looked at fibrous encapsulation that's happening. This is the top one is the parent material, and you can see the bottom one is the surface modified material. Not much fibrous encapsulation that has happened on the implant when compared to with the unmodified polymer. Okay, so in the unmodified form polymer, we see a lot of inflammatory cells. That means there has been inflammatory response because of the foreign material, whereas we don't see such inflammatory cells in the modified polymers which are implanted inside. Then collagen network. Look at this, how the collagen network that has formed. Okay, the bundles of collagen. That is the top figure, top 3 scanning electron pictures. I mean, we do it with the unmodified surface, whereas the modified surface that you can see at the bottom. Okay, so there is a lot of inflammatory things that is happening. You can see the collagens here on the top one. Fibrous capsule. So the implant is completely covered with the with fibrous material, so it forms like a capsule. So when we have the unmodified polymer, it forms, you can see a very thick fibrous capsule is formed around the implant, whereas you don't see that sort of thing happening when you use a modified surface. That's on the right hand side picture actually. Okay, so we see that the unmodified material, when implanted for so many days, it leads to formation of inflammation. So a lot of inflammatory cells are coming out, and there is a fibrous response. So the material is completely covered with these fibrous bundles and collagen formation, whereas the modified polymer is able to withstand this. That means there is no inflammatory response. It is eliciting in the host system. So we tried to semi-quantitative this based on the histopathology studies. So we looked at the different types of cells that are formed on the unmodified material and the modified material, and we tried to semi-quantitate based on the acute inflammatory cells, macrophages, giant cells, fibroblast tissues, collagen networks, and we try to give some numbers and compare the unmodified material, we call it control, and the modified material, this is our test material. Then when we see that, when we put that unmodified material as inflammatory response, keep it as 100, we see once we modify the surface with our technique, we are able to reduce the inflammatory response by almost 1/3. As you can see, again, the connective tissue response also could be reduced by 1/3 here. Okay, so both we are able to achieve. So the modification based on the in vitro studies, we have proven that it's able to prevent the bacterial attachment, different types of bacteria, salt incrustation, as well as they are able to reduce the inflammatory response by almost by a factor of 3 actually. So we have tried to identify a new surface modification technique which could prevent bacterial contamination of this polyurethane urethral stent, as well as prevent the salt incrustation. At the same time, we are able to reduce the inflammatory response. Okay, so that's a problem. Another problem which we looked at is looking at pediatric shunt. These are called pediatric shunts. They are made up of polytetrafluoroethylene. These pediatric shunt are connected to aortic branch. The blood from the left ventricle from through the aortic branch goes to our entire body, top part and bottom part. Okay, whereas if you have the pulmonary artery, the blood goes to the lungs. The blood in the vein, pulmonary artery, does not have enough oxygen, so it goes to the lungs to get enough oxygen. Okay, and then the blood is pumped to the body. So when the blood in the picture, if you see red color, that means there is enough oxygen. Blue color, not much oxygen. So sometimes the blood does not get go to the pulmonary. That means it does not go to the lungs to get enough oxygen. So does not get enough because of so many problems. Okay. So what they do is they place something called a shunt, BT shunt, between the aortic branch and the pulmonary artery, so that the blood is sent to the lungs to get oxygen. Why doesn't the blood get enough oxygen? Because there are problems when the baby is born. There are problems in their heart, so they do not get the blood is not pumped enough into the lungs to get oxygen. Okay, so problems like hole in the heart, so there is a blood leakage. So the blood, instead of going to the lungs through the pulmonary artery, it ends up into the aortic branch. So it's called tetralogy of Fallot. Okay, many reasons, and these are generally found in newborn babies. Okay, instead of getting clearly these four compartments in the heart, there are holes, so the blood is getting short circuited. These are generally found in newborn babies. So because the baby is so new, and they cannot perform an open heart surgery to close these holes. So what they do is they keep these BT shunts so that they drive some of the blood from the aortic branch into the pulmonary artery. The blood goes to the lungs and get the oxygen. When the baby becomes older, that is old enough to have a open heart surgery, they do a open heart surgery and close the holes so that the blood leakage or blood short circuiting doesn't happen. So this is called tetralogy of Fallot. So these BT shunts are made up of polytetrafluoroethylene, and they are generally placed because this problem is generally in newborn babies. Okay, so they use this polytetrafluoroethylene. So there are problems with this material because as the baby grows, all the organs start growing, but these shunts don't grow. So there is sometimes pain, there is sometimes blood leakage. So we wanted to study some of these. What happens to the mechanical properties of the BT shunt over a period of time? And these BT shunts are placed for many years. If the baby gets a pain, or if there is a blood leakage, serum leakage they call it, or if there are any other problems, they may have to remove that and again keep another one. So when the baby becomes older, they may conduct a open heart surgery to close this hole. Okay, so the tetralogy of Fallot happens because, like I said, there is a hole in some of these compartments. Okay, so generally those have to be closed. So this is a picture. This is the polymer that's used is a polytetrafluoroethylene. It's a polymer which is a very inert. It's a strong material. It's an inert polymer. It does not cause any inflammation, but still it seems to have some problems. Okay, so serum leakage is one problem, mineralization, thrombosis, inflammation, all these. So we wanted to look at the physicochemical changes that happens to the polymer after it has been kept in the body for so many years, because like I said, they do that in newborn babies, and these shunts are there in the body until the baby becomes old, when it can undergo a open heart surgery. So these shunts are placed for many years inside the body. So we wanted to look at what are the changes happening, physicochemical changes happening to these shunts. Okay, so this is an unimplanted shunt, and this is after it's been removed, explanted. You can see the blood serum deposit. Okay, on this. These are some scanning electron pictures of the same. These are new shunts. The top picture, you can see after about 2.5 years inside the body of a 1-year-old baby. The shunts, you can see clumping of these are like a braided BT shunt. Okay, they are braided ET shunt. That means there will be fibers which are knitted together, and you can see them clumping together. You can see in these pictures they are all clumped together because it's kept in the body for 2.5 years. There is blood flow inside. Okay, and as you know, it's a pulsatile flow because the blood from the heart flows like a pulse. So because of so many things happening inside, I suppose the braids have clumped together. This is after 2.5 years. You can see this after 1.5 years. Again, there is clumping, but this is of lesser change when compared to this, because this has been in the body for much longer period of time when compared to this, which is 1.5 years, and this is a 1-year-old baby. Okay, so we first performed study called differential scanning calorimetry. So this gives you the heat properties of the polymer. So we wanted to compare the heat properties of the polymer, new polymer and an old polymer, and that tells you the crystallinity changes in the polymer as it is kept in the body for so many years actually. So the explanted polymer, we looked at the heat capacity and compared it with the new polymer, unexplanted polymer. Okay, so the bottom table gives you that information. So there is a decrease in heat capacity is observed. So there is a decrease in heat capacity of the polymer after it has been kept inside the body for a long period of time. So this table tells you that decrease in heat capacity. So when you talk about decrease in heat capacity, so it's become more crystalline. So the polymer has become more crystalline. More crystallinity makes the polymer more stiff inside the body. As you can see, there's a the reference is the control, that is the polymer before getting implanted. So heat capacity is 21 joule per gram. It's come down to 17, 14, 21, like that. Heat capacity has come down with different samples. So then, we looked at the contact angle that tells you the surface energy of the material. Higher the contact angle, lower the surface energy. It's more hydrophobic. Lower is the contact angle, it's more hydrophilic. So as you can see, when it is explanted, because of the attachment of protein, blood protein, and plasma proteins, it's become very hydrophilic. It's come down to 50 degrees, but when we wash it again, it becomes back. Heat capacity has gone down from, like I showed in the previous, 21 to average of 19. Tensile strength has gone down from 14 megapascal to 7. So although it's only blood that is flowing inside, because it's been there for 1.5 to 2 years, tensile strength has gone down quite a lot. Elongation has gone down 682% to 263. That means the polymer has become stiff. When you talk about a stiff material, obviously it's going to give you pain, because material has lost its flexibility. It's no more flexible, and the blood flows inside, pulsatile flow, it become very stiff. So it's giving pain. That's why the polymer, those who have this sometimes start feeling the pain because the material has become more stiff. Okay, there is no permanent protein absorption, because when you wash it with the explanted material, all the protein that's absorbed is removed. So it's more of a surface phenomena. Another interesting thing is the roughness of the material has changed a lot. So we performed something called, looked at the roughness using atomic force microscope. So you see unimplanted material roughness is 1.7 nanometers, but after explanting, it's gone up by almost 300 to 400 times. So although it's just a blood flow, over a period of 1 year to 2 years, material becomes rough. When we talk about rough surfaces, blood flow that can activate the platelet, again, that's a problem. Platelet activation can lead to thrombus formation and thrombosis. So roughness of the material also has gone up. External and internal surface. That is, internal is where the blood is flowing. Okay, so it's gone up. So many things have happened. These are some Fourier transform infrared analysis. It shows the lipids, proteins binding to the surface. So many things has happened to the polymer. It's become rough. It's become stiff. Tensile strength has gone up. The tensile strength has reduced a lot. It's become more crystalline. It's become stiff. Elongation has gone down. That means it's become very crystalline and stiff. So it can lead into pain. It can lead into stiff material. It's no more a flexible material. Because it's rough, it can elucidate the thrombosis also. Okay, these are certain angiogram pictures. A patient who had both the shunt, okay, as the blood flows. If it's a good shunt, you can see a lot of blood flowing nicely here. Okay, Whereas here the shunt is blocked, so obviously the blood flow is also poor actually. So when we removed and compared, when we remove this shunt and this shunt and we can compare, we can see the crystallinity of this material is higher, so it's become very stiff. Because it's become stiff, the blood flow is not very comfortable. When you have a very flexible material, the blood flow is much easier. So the left angiogram, because it's not as stiff as the right hand side, blood flow is also very comfortable actually. So we see that there is a good correlation between the physicochemical properties of the shunt with the clinical findings. So what the patient sees. So that's the interesting thing. So one needs to address issues like how to prevent this type of stiffness of the material, how to prevent roughness that takes place after 1 to 2 years actually. If one could address this, the quality of the BT shunt, the performance of the BT shunt also could be improved further actually. So this is also an interesting study where we didn't find a solution, but we found reasons for certain problems. In this particular example, whereas in the other two examples we found solutions for problems. Here we tried to find reasons for some problems. So the manufacturer, if the manufacturer can address those reasons, then they could make better quality shunts with reduced problems that are faced by the patients. So, as I said, 50% decrease in strength and tensile strength. So it's become not as strong. So there could be serum leakage. Elongation has decreased, 60% decrease. Okay, so that means it's become stiff. No salt deposition. There is a big increase in surface roughness. Okay, there is a fusing or clumping of the fibers like of the shunt. Okay, so once you have clumping, it's become stiff. There is a serum leakage also. And there seems to be a very good correlation between its performance with respect to its physicochemical changes that has taken place. So we used tools like Fourier transform infrared spectroscopy and differential scanning spectroscopy, atomic force microscopy, scanning electron microscopy to understand the changes that has taken place in the material after 1 to 2 years of implant inside the body, and we are able to correlate it with its performance. So that is what this third study is all about actually. So to conclude my talk, polymers are extremely ubiquitous and has many properties that are advantages. We can tailor make properties of polymers. That's the beauty of it. We can have blends, we can have composites and so on. Okay. Main point is the surface properties, because inflammation, bacterial attachment, all these are dependent on the surface of the material. Blood application, thrombus formation, platelet activation, all these are again surface properties. So we need to look at surface. We need to prevent biofilm or attachment of bacteria on the surface. We need to prevent inflammation that's taking place. Biodegradable polymers are very good for drug delivery. In the first problem, I talked about PLGA, that is polylactic glycolic acid, which is very good for drug delivery applications. And as I showed you, it's a highly interdisciplinary. We have the polymer chemists coming into, biotechnologists coming into, and also surgeons. Many case studies which you talked about, unless you have a very close interaction with the surgeon, you will not know what problems they are facing. And so we need to look at solutions without knowing the actual problems faced by the surgeon. So it's extremely interdisciplinary in area. And of course, interaction with hospitals is a must. We cannot do research in the area of biomaterials without the contact with the hospitals, looking at their problems, trying to find solutions to those problems actually. Okay. And finally, let me thank my research scholars, many research scholars, PhD scholars who have worked on all these problems I talked about, funding agencies like DST and DBT, and also let me thank the organizers of this Symposium, Professor Utkarsh, for inviting me to give a talk to you. Thank you very much for your time.
Thank you, sir. Thank you very much. If anyone have a question, you can ask to Doble sir.
If anybody has any questions, I'll be pleased to answer them.
Definitely. Uh, if you don't have any question, we can conclude the session and we can
Or
end the session.
if there is anything in the writing also, I can on the
Yeah,
chat
yeah,
box.
sir. And
Also,
if further also, if anyone have question,
yeah,
they can mail
yeah,
to Doble sir.
definitely, definitely.
Yes, sir. Okay, sir. So there are,
Right.
I think there are no questions. So again, I am thanking to you. Thank you, sir, for sparing your valuable time. And we are fortunate to have you on the FPP session as a chief guest and also as a speaker, sir.
Sure,
Thank you,
sir.
sir.
Sure, sir. Thank you very much. Thank you. Thanks. Thanks for the invitation. Thank you, sir.
Thank you, sir. Thank you.
Thank you.